Welcome to the Surgical Edge podcast for surgical insights, reviews, discussions, and to stay updated. Let's dive in.
So, imagine trying to carve a delicate, completely invisible cobweb out of a really confined, blood-filled space.
Right, which is already a nightmare scenario.
Exactly. And you know that if your scalpel veers off by just like a single millimeter, your patient's cancer is almost guaranteed to come back.
Yeah, the stakes are just incredibly high.
Because, I mean, in most of surgery, you see the pathology and you cut out the pathology, right? Like an inflamed appendix or a damaged valve. It dictates its own physical margins. You're dealing with very tangible boundaries.
But rectal cancer is, well, it demands a complete cognitive shift. You are no longer just looking at the organ itself.
You're looking at the space around it.
Exactly. You're looking at an architectural blueprint of embryological boundaries that are barely visible to the naked eye. It requires this level of spatial awareness that borders on the extreme, honestly.
Yeah, it's a totally different mindset. And before we map out those microscopic fault lines, I want to formally welcome you to the deep dive. We know a lot of you listening today are surgeons, doctors, or medical professionals who are looking to refine your mental models of these incredibly complex pelvic procedures.
Which is such an important thing to constantly review.
Oh, absolutely. And just a quick mandatory note right up front. This content is strictly for reference only. You must always, always follow your local guidelines in your actual clinical practice.
Right. Safety and local protocols first, always.
For sure. So our mission today is really unpacking the anatomical and functional intricacies of total mesorectal excision, or TME.
Which is really the gold standard. And we are synthesizing a huge stack of crucial sources to do this, including standard surgical guidelines, some really fascinating historical papers detailing Bill Heald's original anatomical concepts, and comprehensive pathological studies on Quirke grading.
And the circumferential resection margin, right?
Yeah.
The CRM.
Exactly. The CRM is huge here.
Yeah. We are going to look at why TME isn't just a surgical technique, but like a true spatial masterpiece. Because historically, before this technique was really standardized, surgeons would essentially just dig the rectum out using blunt force.
Which sounds barbaric now, but that was the norm.
It was. And the local recurrence rate for rectal cancer was sitting at a staggering 30%. 30%.
Yeah. And severe postoperative dysfunction was just, considered the cost of doing business. It was expected.
Right, you survive, but your quality of life is severely impacted. But TME completely transformed those survival rates. It dropped local recurrence to under 5% in many series.
It's an incredible leap.
It really is. And it did this not by inventing some fancy new robotic tool, but basically just by respecting a naturally occurring embryological boundary.
Right, it's all about anatomy.
So to understand how that works, we need a perfect 3D mental map of the pelvic fascia. So I guess the first question is, what exactly are we trying to remove here? And what must be left behind?
Well, the primary target is the mesorectum. You have to understand that during embryological development, the rectum doesn't just form as this bare tube.
Right, it's not just a pipe.
Exactly. It develops encased in a really thick, distinct layer of fatty tissue. And that tissue serves as its primary lymphatic drainage basin.
Okay, so that fat is the mesorectum.
Yes. And it contains the perirectal lymph nodes, the lymphatic vessels, and potentially microscopic tumor deposits that might have, escaped the primary rectal mass.
Because if a tumor spreads locally, it almost always seeds itself into that surrounding fatty envelope first.
Right. So the entire envelope has to come out as one sealed unit.
It has to be completely unbreached.
Unbreached is the perfect word. And wrapping that fatty mesorectum is a very thin, super delicate fibrous layer called the visceral mesorectal fascia.
Visceral meaning relating to the internal organs.
Right. So that forms the outer skin of the package you're trying to remove. But right next to it, lining the rigid walls of the bony pelvis, is a completely separate fascial layer, which is the parietal pelvic fascia.
Parietal being the wall of the body cavity.
Exactly. And this includes the presancral fascia in the back and the endopelvic fascia on the sides.
Okay, so let's try to visualize this as two envelopes. You have an inner envelope, which is the visceral fascia holding the rectum, the fat, and the lymph nodes.
Right, the package.
Yeah. And then you have an outer envelope, which is the parietal fascia lining the pelvic cavity itself.
Yes. And the TME plane, the actual physical space the surgeon operates within, is the micromillimeter gap between those two envelopes.
Just this tiny, tiny gap.
Exactly. Because between those two fascial layers, it's a thin layer of loose areolar connective tissue. It has a very delicate, almost alveolar structure.
Oh, like a web.
Yeah, exactly like a web. Back in 1982, when Bill Heald first conceptualized the specific approach, he famously described this areolar space as the holy plane.
I mean, calling it the Holy Plane sounds a bit mythical for a surgical textbook, doesn't it?
It does. But Heald used that term because of how miraculous it actually appears when it's properly navigated. It is a smooth, naturally avascular potential space.
Avascular meaning no blood vessels.
Right. If you find the exact interface of that areolar tissue and you stay perfectly within it, the surgery is almost entirely bloodless.
Oh, wow.
Yeah, you open it up through sharp dissection, using tension to pull the two envelopes apart, and you simply snip the areolar fibers connecting them.
Okay, so going back to our analogy, it's like those two envelopes are glued together with a delicate cobweb.
That's a great way to picture it.
And you want to extract the inner envelope as a completely intact cylinder without tearing the paper of either envelope. You only want to cut the cobwebs?
Yes, just the cobwebs, because the integrity of that inner cylinder dictates the patient's future, quite literally.
Because if you tear the inner envelope, the visceral fascia,
Yeah.
you risk spilling viable tumor cells, right?
Exactly. You spill cells, and you leave infected lymph nodes behind in the pelvis, which is the primary driver of local recurrence.
But on the flip side, what if you tear the outer envelope, the parietal fascia?
Well, then you are suddenly digging into the presacral veins.
Oh, that sounds bad.
It's very bad. That causes massive, difficult-to-control bleeding. And worse, it severely risks severing the underlying hypogastric nerves and the pelvic plexus.
Which control urinary and sexual function.
Right, so staying perfectly in that cobweb layer gives the surgeon this incredible dual benefit.
Right, you achieve oncological clearance because you extracted the entire lymphatic package.
And you achieve functional preservation because you left the delicate wiring of the pelvis completely untouched behind that outer envelope.
That makes so much sense. But understanding the logic of the holy plane conceptually is, it's only the first step. Translating that mental map into physical navigation during surgery, deep inside the tight, constrained, and often poorly illuminated space of the human pelvis that requires a very strict adherence to specific landmarks.
It does. It's incredibly technically demanding.
So let's walk through that physical navigation. How does a surgeon actually orient themselves in this 3D space intraoperatively without getting lost?
Well, the consensus in the sources points to a highly systematic medial to lateral approach.
Okay, start in the middle and work outward.
Exactly. You begin high up by dividing the inferior mesenteric artery, the IMA, securing control of the superior rectal artery early.
Manage the blood flow first.
Right. Once that vascular inflow is managed, you begin opening the avascular plane behind the upper mesorectum, moving downward.
Now, the posterior dissection seems to be where the anatomy gets particularly unforgiving, because the sacrum isn't a straight drop, right? It curves inward, creating almost like a blind corner.
Yeah, that posterior curve is a major hazard. The most critical landmark here is the superior hypogastric plexus. The correct TME plane lies strictly anterior to these hypogastric nerves.
So you have to stay in front of them.
Always in front. Dissecting posterior to them means you have punched through the outer envelope and entered a deeper plane against the presacral fascia.
Which means you hit those veins we talked about.
Yes. You will injure the nerves and you will hit the presacral veins, which are notorious for causing life-threatening hemorrhage because they actually retract directly into the sacral bone when they're torn.
Wait, they pull back into the bone.
They do, which
Yeah.
makes them incredibly difficult to tie off or cauterize.
Oh, wow. So avoiding them is absolutely critical. You stay in front of the nerves. But as you navigate down, following that sacral curve, the sources mention a specific, really tough roadblock. Waldeyer's fascia.
Ah, yes, Waldeyer's fascia, or the rectosacral fascia. This sits roughly at the S4 level.
Okay.
And unlike the delicate cobweb of the areolar tissue we've been talking about, this is a dense, thick, fibrous band that physically tethers the mesorectum to the sacrum.
So it's not going to just gently peel apart.
No, it does not yield. You must apply significant upward traction on the rectum to expose it, and then sharply divide it with your scalpel or an energy device.
Okay, so cutting Waldeyer's fascia basically releases the rectum from that sacral curve.
Exactly. It allows you to mobilize it distally all the way down to the levator ani muscles on the pelvic floor.
All right, so that handles the posterior drop. Yeah. What about the lateral boundaries?
Laterally, the pelvic anatomy sort of fans out. The plane runs just outside the visceral mesorectal fascia, but you must constantly ensure you are staying medial to the pelvic plexus.
Medial, so towards the center.
Right. The autonomic nerves here spread out laterally like a spider web. If you drift too far laterally, you draw your dissection straight into that neurovascular plexus.
And what happens then?
Profound postoperative bladder atony and sexual dysfunction.
Right, so you have to stay tied to the package.
Yeah.
Now, moving to the anterior navigation, the front of the rectum. The anatomy actually fundamentally changes depending on the patient's biological sex, right?
Yes, it does. Below the peritoneal reflection, the anterior dissection requires navigating the rectogenital plane.
Okay, so how does that differ?
In men, this means dissecting between the anterior mesorectal fascia and denonvillier's fascia, carefully separating the rectum from the prostate and seminal vesicles.
Got it. And in women?
In women, the navigation follows the rectovaginal septum to separate the rectum from the posterior wall of the vagina, and the space here is incredibly thin.
I can imagine.
The risk of breaching the tumor or injuring the genitourinary organs is at its highest right here.
Okay, wait, I have to push back here for a second.
Sure.
You are describing this perfectly avascular, holy plane made of delicate areolar tissue that just naturally separates two fascial envelopes.
Right.
So if this plane is so clearly defined and so easily separated by tension, why are surgeons still messing this up? I mean, why not just sweep your hand down into the pelvis? Use your fingers to bluntly separate the tissues and save, like, an hour of OR time.
Well, it's a tempting thought.
Right. If the boundary naturally exists, wouldn't blunt force just naturally follow the path of least resistance?
The problem is that the path of least resistance is rarely the true anatomical boundary. Mechanically, yeah, blunt dissection might feel faster. You push, the tissue yields, and you feel like you are making rapid progress. But the microscopic reality of blunt force is much more destructive. Blunt tearing creates immense shear stress on the tissues.
Oh, I see. It rips the envelopes instead of cutting the cobwebs.
Exactly. Blunt force compels the tissue to tear along lines of mechanical weakness, and those weaknesses are often created by the tumor's inflammatory response rather than the natural embryological planes.
So you think you're in the right space, but the tumor has changed the tissue integrity.
Right. So you run a massive risk of breaching the visceral fascia, which completely compromises your oncological margin. And simultaneously, you risk tearing into the parietal fascia, avulsing the very nerves you are desperately trying to save.
Wow. That is why the modern standard demands meticulous, predominantly sharp dissection.
Yes, you have to see what you are cutting.
Always under direct vision.
Always. You apply precise traction to the rectum and counter traction to the pelvic wall. This tension pulls the two envelopes apart, exposing that avascular cobweb layer so your instrument can cleanly divide the fibers.
Without transmitting all that shear force to the fascial layers themselves.
Exactly.
So, if blunt tearing destroys this delicate oncological envelope, how do we actually prove the surgeon stayed in the lines? Because once the surgeon has navigated the hypogastric nerves, cut Waldeyer's fascia, and extracted the rectum as one intact cylinder, the surgery is basically over, right?
For the surgeon, yes.
But the validation of that work shifts entirely from the operating table to the pathology lab.
Right. The pathologist provides the ultimate report card.
And we're looking at a stack of pathology sources detailing the CRM and Quirke grading. Let's start with the CRM. What exactly is the pathologist measuring there?
So CRM stands for circumferential resection margin. When the pathologist receives the extracted specimen, they look at the outer wrapper, the non-peritonealized radial margin.
Which anatomically corresponds exactly to the visceral mesorectal fascia we've been discussing.
Exactly. So the pathologist covers the entire outer surface of the specimen in ink and then slices it, kind of like a loaf of bread, to examine the cross-sections under a microscope.
They are looking for the distance between the ink and the cancer.
That's it. They measure the exact distance in millimeters from the deepest invasive tumor cells to that inked outer fascial layer.
And what's the threshold for a bad outcome?
A positive CRM is defined as tumor cells being 1 millimeter or less from the inked margin.
Just 1 millimeter.
1 millimeter. Finding a positive CRM is a catastrophic red flag. It is one of the strongest independent predictors of local recurrence and poor overall survival.
Wow. Even with other treatments.
Yes, and that holds true even if the patient receives aggressive chemotherapy and radiation afterward.
That's terrifying. So the goal of staying in the perfect TME plane is to maximize that physical buffer zone, ensuring your CRM is far wider than that 1 millimeter threshold.
Right.
But that has to be especially challenging in the mid and low rectum, where the bony pelvis narrows and the mesorectum physically tapers down, right? It leaves a much thinner fatty envelope to work with.
It is much harder down there. That's why preoperative MRI is the critical tool for managing that narrowing space.
So they map it out beforehand.
Long before the first incision, a high-resolution MRI maps the tumor's exact distance to the mesorectal fascia. It essentially predicts the CRM risk.
So if the imaging shows the tumor is threatening the fascia, what happens?
It dictates the need for neoadjuvant chemoradiation to shrink the tumor back from the edge. Or it warns the surgeon that they cannot stick to the standard TME plane in that specific quadrant.
They have to go wider.
Right. They will have to widen their dissection to include adjacent structures just to achieve a clear margin.
Okay, assuming the surgeon attempts a standard approach, though, the pathologist isn't just measuring the distance to the tumor, they are auditing the physical quality of the surgical technique itself.
Yes, they are looking at the handiwork.
And this brings us to the Quirke grading system, because a surgeon cannot hide a torn envelope from the pathologist.
No, they cannot. Phil Quirke really revolutionized the pathological assessment by introducing this three-tier grading system. It evaluates the macroscopic quality of the TME specimen.
So it directly scores how well the surgeon respected that fascial envelope. Walk us through the stakes of these 3 tiers. What's the best grade you can get?
The top tier is the mesorectal plane. This is the gold standard. Under the microscope, the pathologist sees a completely intact, smooth mesorectal surface.
Perfection.
Right. There might be, minor superficial irregularities, but there are no deep defects. And the specimen does not abnormally taper or cone toward the distal.
So sorry for the interruption, but this is important. We need your support to help us grow, reach more surgeons, and keep delivering cutting-edge surgical content. Press the support button and donate now if you like what we do. Let's get back to the podcast.
So this grade proves the surgeon navigated the holy plane perfectly. They kept the inner envelope pristine.
Exactly.
But what happens when they slip?
That drops the specimen to the middle tier, which is the intramesorectal plane. Here, the pathologist notes moderate irregularity.
Okay, meaning what, visually?
The surgeon's scalpel has created defects that dig into the mesorectal fat. This means they drifted out of the areolar plane and into the envelope itself.
Oh, I see.
However, the cuts haven't gone deep enough to expose the muscular layer of the rectum.
So it's a passing grade, but a dangerous one. You nicked the envelope, but you didn't expose the letter inside.
That's a good way to put it.
And the lowest tier.
The lowest tier is the muscularis propria plane, and this represents poor quality surgery.
The failing grade.
Yes. The specimen exhibits deep, ragged defects that completely breach the mesorectum, exposing the bare muscle of the rectal wall.
Wow, so the surgeon just lost the anatomical plane entirely.
Completely. They were dissecting within the rectal wall and almost certainly leaving mesorectal tissue and potentially microscopic tumor deposits behind in the patient's pelvis.
Getting that top-tier Quirke grade isn't just an academic exercise then, or a point of pride for the surgeon. It fundamentally changes the patient's life.
It determines their survival.
The data in our sources shows that patients who receive a mesorectal plane TME have drastically lower local recurrence rates. And because achieving that grade inherently requires sparing the outer parietal envelope, those same patients retain their urinary and sexual function.
Yes, the stakes of this grading system couldn't be higher.
The feedback loop between what the pathologist identifies under the microscope and what the surgeon adjusts in the operating room, that has to be the primary engine of surgical quality improvement.
Without a doubt. It forces surgeons to honestly evaluate their technique.
And because we now understand this plane so thoroughly, surgeons are no longer applying a one-size-fits-all approach, right? They are tailoring the extent of the excision based on the tumor's exact location.
Right.
We've established TME as the gold standard for mid and low rectal cancers. But if a patient has an upper rectal cancer, dragging the dissection all the way down to the pelvic floor seems like, well, an unnecessary risk to the nerves.
It is an unnecessary risk. For upper rectal cancers, the approach shifts to a partial mesorectal excision, or PME.
Okay, so how does the navigation change for a PME?
The fundamental principle of the fascial plane remains identical. The surgeon still locates the avascular areolar space and meticulously keeps the mesorectal envelope intact.
So you're still on the holy plane.
Yes. However, instead of dissecting all the way down to the levator animuscles, they only need to secure a distal mesorectal margin of at least 5 centimeters below the lower edge of the tumor.
Okay, so you cross-cut the cylinder 5 centimeters below the pathology. rather than taking the entire tube.
Exactly. Studies confirm that a 5 centimeter margin is oncologically adequate for higher tumors because lymphatic spread rarely travels downward more than a few centimeters.
Oh, that makes sense.
And sparing the patient a deep pelvic dissection significantly reduces the risk of autonomic nerve injury.
Now, our sources also dive into modern, highly nuanced approaches, specifically these membrane-based classifications like the 4 fasciae and 3 spaces concept.
Right, which gets very granular.
Yeah, it sounds like dissecting on an almost microscopic level, allowing surgeons to tailor the radial and distal extent based precisely on the tumor stage.
These newer classifications attempt to formalize the exact fascial sublayers and potential spaces involved in the pelvis.
So they're breaking down the spaces even further.
Yes, they offer a theoretical framework for highly tailored surgery, particularly for complex, advanced, or recurrent tumors, while still anchoring the procedure within the fundamental TME boundaries.
But for the surgeons and trainees listening to this right now, facing these incredibly nuanced, tailored approaches can feel overwhelming.
Oh, absolutely. It's a lot of theory.
So what is the practical takeaway when trying to integrate these membrane-based classifications into actual clinical practice?
Simply put, you have to walk before you run. Before any trainee attempts to implement advanced, tailored membrane classifications, they must absolutely master the standard TME plane.
Get the basics down perfectly.
Right. The priority is building an unbreakable core mental model, locating the visceral fascia, identifying the parietal fascia, and maintaining discipline within the avascular interface between them.
You have to master cutting the cobwebs on a standard case first.
Exactly. Once a surgeon can consistently deliver a mesorectal plane Quirke grade on a standard TME, then they have the technical foundation to start adopting nuanced modifications.
So the Quirke grade is basically your license to start tailoring.
Sort of, yes. Intraoperative decisions, such as determining exactly how far distally to dissect, or recognizing when you must intentionally breach the outer envelope to take adjacent structures for a threatened CRM, those must always anchor back to that foundational fascial concept.
Right. Modifying a surgical plane is only safe if you know exactly where the original plane resides.
Beautifully said.
So if we synthesize the guidelines, the history, and all this pathology we've explored today, becoming a master of this procedure really requires adopting a specific mindset. You have to become a specimen-oriented surgeon.
A specimen-oriented surgeon, yeah.
You aren't focusing on the empty hole you were leaving behind at the patient's pelvis. Your focus is entirely on visualizing the intact package you are creating to hand over to the pathologist.
Because that package tells the whole story. A specimen-oriented surgeon holds that 3D mental model of the embryological planes constantly in their mind. They utilize meticulous, sharp dissection to respect those boundaries. And most importantly, they demand routine pathology feedback, scrutinizing their Quirke grading and CRM status to continuously audit and refine their physical technique.
It is a continuous loop of learning, isn't it? And just a beautiful marriage of anatomy, technique, and pathology.
It truly is.
To close out our deep dive today, I want to leave you with a final thought to ponder. We opened by discussing how TME forced surgeons to stop looking at visible masses and start reading the invisible architectural blueprints of the body. We mapped the holy plane.
We move from macroscopic disease to fascial integrity.
But as preoperative MRI imaging reaches astonishing new levels of precision, and as molecular pathology continues to evolve so rapidly, we have to wonder what the next decade holds.
The technology is moving so fast.
It is. How might the definition of the holy plane shift? Will it evolve from a universal anatomical boundary into a highly personalized, patient-specific microscopic map?
That's a fascinating thought.
Imagine a surgical environment in the near future where augmented reality overlays the patient's specific fascial integrity and nerve web directly into the surgeon's field of view in real time.
Oh, wow.
It could show the surgeon exactly where their specific holy plane wavers, thickens, or fuses due to their unique tumor biology and inflammatory response.
Pushing past the macroanatomy of the fascia to navigate its microenvironment dynamically like that, that is undoubtedly the next great frontier in surgical oncology.
It's a really exciting paradigm shift to consider as you reflect on your own clinical practice and how you visualize the operative field. And before we let you go, a quick reminder, if you like this deep dive, please do not forget to share it with at least one of your colleagues or friends to help spread the word. Discussing these mental models with your peers is really the best way to cement them.
Peer discussion is such an essential part of refining that surgical mental map.
Absolutely. Also, be sure to check out our YouTube and other social media pages for more content. And make sure to browse our previous season and episodes. We feature several really relevant topics on surgical techniques and spatial anatomy for your continued learning. We will see you on the next deep dive. Keep refining those mental maps, and remember, sometimes the most important boundaries in surgery are the ones you can barely see.
Thank you for listening to the Surgical Edge podcast. Don't forget to like, share, and subscribe. Help us grow and deliver even more relevant surgical content by pressing the support button. Your contribution truly makes a difference. And don't forget to share with us your advice, feedback, and the topics you would like us to include.